today is Dr. Suzanne Spencer. She is a family practice physician, and she has real-world experience in what I call the patient-centered medical home model. She's uniquely qualified to attest to this model because she started life off as a physicist. And most of you who know physicists know that they're constantly analyzing, questioning, trying to figure out how to work things. She had a graduate degree in physics, and after that she got a degree in medicine from the University of Washington, and she was medical chief at Group Health in Victoria, which was a pilot site for the medical home model. Ladies and gentlemen, please help me welcome Dr. Suzanne Spencer.
So I wanted to first say that I have my degree in elementary particle physics, so I should make this fairly simple. I think we have slides, and basically people want to know what is a medical home, and it really is a tough concept to explain in a few words. Basically, the vision that we have is that we would combine core primary care principles with relationship-centered care, that's doctor-patient, or primary care relationship to the patient. I mentioned reimbursement reform. You've already heard about that, so that's certainly part of it. We have new information technology and combining that with the chronic care model. So basically, this is saying the primary care, you need to step forward, reintroduce yourself again as family physicians, and take care of patients preventatively. So in the design principle, the relationship between the patient and the physician is of primary importance, and that all the processes we were going to introduce had to be patient-centric. Now, I know these are all kind of fluffy words, but it's really a real concept that everything is designed not for the benefit of the business office or for physician hours, but to make that patient's experience coming into clinic of primary importance. What would they like? What do they need? When do they need it? So, as part of the cost function, this is all stuff you know. Next slide. We know that healthcare costs are rising. Why do we have this model? I think because we believe not only will we deliver better care, but we can do it more effectively because we can coordinate that care. So, next slide. What would happen if we changed our model from the come and get it type of practice, the reactive medicine model, face-to-face visits? What if we actually had strategic planning and went out and identified those patients that have chronic illness, and we really proactively address these? So next slide. The 5 drivers of chronic care, as you know, are coronary artery disease, chronic lung disease, diabetes, depression, and asthma. And there are guidelines and evidence-based models out there for each one of these diseases. Next slide. So what we planned as a clinic to look at this care. Great. I'm going to load this. Great. All right. So we wanted, again, patient-centered approach. We realized we had to redesign the whole sort of format and transform this practice from sort of the physician authoritarian to a team sort of model, again with the premise that most patients count the time with their doctor as when the visit really starts. So practically, what did we do? Well, in our clinic, we had 2,300 patients per FTE doctor, which is a lot, let me tell you. And we actually reduced these panel sizes. This was a painful process. And we did it some by attrition, but by bringing in new docs and asking patients to make changes to some of the new docs. We developed longer appointment times, 30 minutes, mindful that we had to provide access. So if you have longer visits, you're going to have to figure out a methodology to take care of other patient needs. And that's where our technology came in. And we learned how to finesse secure messaging, email messaging with patients, so that they had actually 24/7 access to their healthcare team. They could write, if they're up at 3 in the morning, they could write us. We didn't necessarily write them back at 3:01, but we certainly did get back to them in a timely fashion. We did a lot of outreach. We did a lot of something called HRA, where we had them fill out applications or questionnaires about their health needs. And we did a lot of something called point of care service, where if the patient came in for an upper respiratory infection, we actually looked at their whole medical life and addressed all the chronic care needs. Now, it seems fairly simplistic, but this was enormously difficult. But what it resulted with is, I think as family physicians, we started to feel like we're doing the right work. We're doing family medicine.